Good morning, everyone. My video today is on inverted ILM flap in large macular holes. We usually This is a fairly common procedure that is performed nowadays with significant visual recovery and anatomical closure of holes. So what we do is a 25 gauge pars plana vitrectomy. We do complete the core vitrectomy, then go for tricot wash, induce PVD, then we stay in the ILM with BVG, which is provided by Auro Labs. After staining the ILM, we start the ILM peeling using ILM peeling forceps, or in some cases if you're not able to raise the ILM flap properly, you can use a scraper which is provided by Alcon ILM scraper, which lifts the ILM, and then without much damage you can just peel the ILM circumferentially. After you start peeling the ILM circumferentially, what I do, as you can see in this video, just tend to go as you do in a rex around the macular hole. I started practicing first I used to go with a small flap, but after some time I realized that if you go for a small flap, there's a chance that if you snap this thing from the edge of the macular hole, or you tend to just if the flap snaps, then the whole surgery is in jeopardy. So what I usually do is I take a large flap, and after I finish peeling it circumferentially, I just go and peel it up to the edges of the macular hole, and I usually maintain a very slow pace in peeling the ILM flap because I don't want to dislodge the flap from the attachment, which is the main aspect of this surgery to be successful. If you once the whole flap is completed, I inspect around the macular region, and I gently peel the ILM, whichever it is, the ILM is remaining. So once I complete this, I slowly go pick one edge, mostly the superior edge of the ILM flap, gently start tucking the ILM flap into the hole. And once I finish ILM peeling and the flap doesn't stay in position, and I never use a tamponade like PFCL or this thing to maintain the flap in position. After the ILM flap, I usually gently fold the ILM flap using the forceps itself and slightly pulling it towards the hole and pushing it like just slowly into the macular hole. So once I just finish plugging the macular hole with the ILM flap, I ensure that the flap is completely in position, because once you start fluid air exchange, there is a chance if it's not properly plugged in, the flap can dislodge from the macula. After I finish this, I start fluid air exchange with a very low vacuum. The vacuum must be as low as possible and linear, and you must keep an eye on the flap of the macular flap, so that it won't dislodge from the macular hole. So once the fluid air exchange is completed, in the last phase of the fluid air exchange, what we do is we can go take the active suction off, and you can go with flute needle, or as I told you, linearly as slow as possible you can dry the macula. Once it is there, your surgery is almost complete, because if it is in position by the end of fluid air exchange, there is a fair chance that it won't dislodge. As you can see, this procedure ensures complete closure of macular hole on the table itself. So the tamponade depends upon what what you want to choose. You can go for a cast tamponade or an air as a tamponade. The main thing I observed after this is there is 100% closure of macular hole if the flap is in position by the end of fluid air exchange. And hypothetically speaking, ILM flap helps in inducing gliosis and helps in macular hole filling with proliferating cells that enhance closure. What happens usually is, in healthy retina, neurons are surrounded by Muller cells, and if retina is detached or otherwise damaged, macrophages like cells from the vitreous may infiltrate the retina. These cells may activate Muller cells via TNF alpha, inducing gliosis. Moreover, the field of ILM itself may contain Muller cell fragments. Therefore, ILM peeling alone can induce gliosis. Thus, if a segment of peeled ILM is left in the hole, it may provoke gliosis both inside the retina and on the surface of the ILM. This hypothesis is based on histopathological findings that were published in a study in an American Academy of Ophthalmology in 2016. So, as I told you, all the cases that I operated from the past 1.5-2 years, almost 15 cases, all the holes were closed completely, and I could attain both anatomical closure and the patient was functionally improved. The visual acuity also improved. Thank you.
Thank you, Dr. Pavan. Very well presented.